Are we ready to get going?
I think, Kathleen, whenever you're ready, I guess we're ready to go.
Thank you very much, everybody, for taking time out of your day so we can talk about Connie. I know we've been hearing a lot about it, and we are able to welcome today to this webinar some of the Connie team themselves. I just want to notify everybody that we are recording this and will be loaded onto the CSDA website for members that are unable to attend because they're probably with patients right now. So we want to make this information available to everyone. First and foremost, I'm Kathleen Garrity. I'm the Executive Director of the CSDA. On the call is also Karen Wright, who is CSDA staff who's been point person on Connie. We have been fielding a lot of calls from our members, and we've also been talking to the Connie team about how we can streamline this process for our members to be able to be in compliance with the mandate that's in place and what it means for the future. So I want to turn it over to them to kind of lay it out, and then we're going to have an open question session. I know you all have a lot of questions, and I want to make sure that we're talking to this team respectfully. They are doing their job to implement a mandate, and they are trying very hard to understand the dental world in a timely fashion so that everything can work seamlessly. So we're going to try to do this in a collegial way and to move forward. And I also want to let you know that Connie will have a booth at our annual meeting at Mohegan Sun on May 11th and 12th. And they will be there for informational purposes to help you and your team to implement the necessary pieces so that you can be in compliance. So thank you to my Connie team. I'm going to turn it over to Jen now.
Thanks, Kathleen, and thanks, Karen. I appreciate the opportunity for us all to be here. As we said, there will be an opportunity for Q&A. We also do have, or you should have at the bottom of your screen, a Q&A little icon that will enable you to put questions as you're thinking about them. If there are questions that we can easily get through while we're on the call, Tracy or Carrie will just go ahead and respond to those questions to try to get them out there for everybody. I think all the lines are muted just so that we don't have to deal with a lot of background noise and everybody can hear the presentation. And as Kathleen said, this will be recorded and we will send out the slides and have links to everything when it's all done. So thanks again for the opportunity to present here. I am going to attempt to share my screen and hopefully it will work. Let's do the slideshow, and I am assuming, Tracy, can I get a thumbs up if it all looks good?
Looks good.
Okay, perfect. Thank you. So again, Jen Searles, I'm the Connie Executive Director. I also have with me Tracy Townsend, who is an account manager and will be leading a lot of technical integrations for the Connie team. We also have Tony Cincagrono, who is a Connie account manager, as well as Carrie Newlish, who's been leading some of the outreach and onboarding efforts. So there's a team of folks to try to help answer questions. The goal is to try to get as much information out to everybody as we can in this session. So Connie, as you guys have heard, is the statewide health information exchange for the state of Connecticut. We were enabled through state statute in about 2017. The Connecticut General Assembly passed a law that started the process of building the statewide HIE. We are required through that mandate to empower consumers, and we're also required to assist healthcare providers and physicians, the state of Connecticut, and insurance carriers. And the healthcare providers and physicians is a very broad category, as we'll talk about a little bit later, but it does encompass sort of anyone licensed by the state to provide healthcare services. Our mission is to enhance the health and well-being of Connecticut's residents. The legislature, as they built this idea of Connie, set out 11 goals for Connie, all the way from being standards-based, promoting the highest levels of interoperability, as well as making sure that patients will get free access to their complete medical record across all healthcare settings. So there's a number of goals out there that we're really trying to achieve with Connie. We also believe that mission of sort of coordinated care across the healthcare ecosystem is what will ultimately empower physicians and patients in their own healthcare. We think the tools support clinical decision-making, again, across all healthcare settings. And we are bound by law to keep patient information confidential and secure, and also advance the state's public health goals. So we were deemed operational on May 3rd of 2021, and being deemed operational was a process by which the Office of Health Strategy, which is a state agency who has administrative oversight over Connie, because we are an independent not-for-profit, so we're not a state agency, we're not even a quasi-state agency. The Office of Health Strategy deemed on May 3rd that Connie was operational. They listed on their website the tools, technologies, and services that Connie had, and that was sort of the initial start of a time clock that you see here. And why that date is important is the legislature within that Connie statute, or as part of that Connie statute, laid out some timeframes for organizations to get connected to Connie. And so what you see here is language from the statute, and certainly we can share the statute with anyone on the call who'd like to go take a look at it. But within 1 year of commencement of operations or being deemed operational, all hospitals and labs had to apply to begin the process of connecting and participating in the HIE. And within 2 years, anyone licensed by the state to provide healthcare services has to begin the process of connecting. And so 2 years of that May 3rd, 2021 date is obviously coming up at May 3rd of 2023. And that licensing for healthcare providers includes primary care, specialty physicians, skilled nursing facilities, hospice, hospitals, labs, behavioral health providers, dentists, and the like. So it's quite a broad statute, and it includes not only, as you can see, organizations, but it also includes individual providers as well. So connecting and participating has been, or as we've been pulling this out and talking to organizations, has really been about sharing your patient's demographic and clinical information within Connie in the HIE. There is no one set data type, as I'm sure if you have an electronic dental record, you're well aware that your data types, your feeds, if you have them within your system, are going to be different than what a primary care physician is going to have in their electronic medical record or their electronic health record. And so we try to customize what that means by type of provider and what type of system they have. And then participating really is appropriately accessing those health records for your patients in the context generally of patient care. And so if there are questions about your patient's care team, or what medications are they on, or what allergies do they have, you would access Connie to be able to see and incorporate that information in the course of patient care. And the very first step, and sort of the real mandated step, is to complete and submit your commitment to connect form by May 3rd of 2023. I believe communication has gone out to all of the Dental Association's members with that date and a link to the Connie commitment to connect form, because we've received hundreds of them over the past couple of weeks. And I know I've even seen some contracts come through. But the main thing I want to sort of lay out for folks is the first main compliance date is by May 3rd to complete that commitment to connect form and get it into Connie. And what that does is it enables us to put you in the queue to start the process, and it enables us to know who's out there and try to prioritize implementation by EMR so that we can make it as simple and as painless as possible for all participating organizations. Okay. So I think there may be some questions about why anyone would want to participate in Connie and what that might look like for dental providers. And we actually had we had an intern who had been working with the Oral Health Initiative in the state of Connecticut, who was both she was a dental student and also public health graduate. And did some work taking a look at the benefit of an integrated approach for healthcare. Connie's belief, and I think we're seeing now as we all get a much better understanding of what it takes to really manage a patient's health, is that there is no one data set that is the only thing necessary to take care of a patient. And we really want to have a holistic and integrated approach that would include dental health, behavioral health, mental health, and clinical data, as well as ultimately some social determinants of health, because we know that plays such a big impact. But the student did some querying and talking with folks in other states where dental data is incorporated in the HIE to get some benefits of accessing a clinical portal for dentists. And so perhaps, and perhaps you guys will have even other ideas that we haven't put on this list, but being able to review relevant clinical history that could impact your patient's dental treatments, we think is potentially a benefit of being able to log into Connie. So seeing if your patient has diabetes or a stroke history. Medications are one area that we're extraordinarily proud of within the Connie portal. We've spent a lot of time working with pharmacists and clinicians to look at data that we get into Connie and building a comprehensive medication history work list within the system. And so we have somewhere in the neighborhood all of the hospital systems in the state are providing data into Connie. A lot of the larger healthcare groups are providing data into Connie, and we're able to take medication information from all of those data feeds, standardize it, deduplicate it, and then present it in a view that allows a clinician to be able to see a really succinct view of a patient's medications. Allergies are going to be one of the next items that we try to pull together, as well as problems that we get from organizations, so problem lists in there as well. We also enable viewing of a patient's NARCS report and hitting the prescription monitoring program. So a clinician can log into the Connie portal, be able to look up relevant problems, allergies, meds for their patient, but also take a look at their patient's NARCS report through the PMP without having to log into another system. So we've tried to make it streamlined so that you can do everything in one workflow if you're a clinician looking up information. We do know from our clinicians that there is relevant information from dentists that we think are key to have in Connie. One area of Connie that I'm always surprised, and Tracy is going to take you through this, and I shouldn't be surprised by it anymore, is the care team. And the impact of knowing a patient's care team is really critical for all the other members of the care team. So being able to understand who the patient's primary care doctor is, dentist, cardiologist, urologist, OBGYN, and the like is really important and really impactful. And being able to provide that data up to clinicians in the system, I think, is going to be really relevant and important, as well as any dental related diagnoses that could end up impacting a patient's overall health. There are benefits to a coordinated approach to healthcare for patients. And we hope with the advent of dental data coming into the system and also dental providers participating in Connie, that we're going to be able to build out even more use cases that might be relevant both to our clinical partners and our dental partners. As we keep going, this infographic just really helps walk you through steps of what it takes to get to Connie. We talked about that commitment to connect form. It really is that first step into Connie. It enables us to know the organization that we're dealing with. It enables us to get your contact information, and it really provides us that first critical piece of data so that we can put you on the list, assign an account manager, and start working with you on the next steps of the process. And the next major step on the process are legal documents. Connie has the data for roughly about 4.2 million unique patients in its database. We expect that all of our participants who are both submitting data as well as those who are accessing data sign on to some common rules of the road about how to be good stewards of this data and information. We expect that everyone is going to use this data responsibly and within the bounds of the laws that govern both their use and access as well as Connie's. And so those legal documents really outline that set of responsibilities and accountabilities, again, both on the sending organization, so dental providers who are able to send data, as well as Connie for receiving that data, and then other organizations as they use that data. We really want to make sure that everyone is operating on those common rules of the road. Once we get past the legal documents, then we start working technically to understand what system do you have, what data is easily able to be accessible from that system. Do we already have vendors that have built hubs for them? You'll hear me talk about hubs a little bit through here, and your account manager may as well. where we have identified pockets of providers on a single EMR platform, we try to connect and build a hub for that platform so that it makes it easier for the participating organization to sign on to Connie, but also to make it easier to get data to Connie from that participating organization. So for example, many of our medical providers use an EMR called Athena. We've been able to build an Athena hub. So it's one-stop shop for Connie to get data from Athena, and it's one stop for Athena's clients to be able to send data into Athena. Makes it a much easier process for everyone involved. And then once you're connected, we'll let folks know on our website that you're a connected provider, and then stay in touch and participate in Connie. I'd really like to expand the use of our system for more dental use cases and have a closer tie-in and connection in there. And the best way to do that is to involve all of you on our committees and on our work groups, and to think about use cases and where we can make Connie really useful and helpful for you and for Connecticut's citizens. So I don't think we wrote out the language specifically from the statute, but the statute does recognize that not everyone has an electronic system capable of connecting to Connie. And what the statute says is if you do not have one capable of connecting to Connie, then the mandate requires you to get a direct email address. And direct is really nothing more than a secure email messaging system. It has what are called direct protocols, and they are HIPAA compliant protocols that make sure that that providers are sending data securely amongst each other about their patients. So it's really maintaining a very HIPAA compliant workflow from the person sending an email to the person receiving the email. We can also, so let's say you're a dental provider and you don't have an electronic dental record, but the idea of being able to look at Connie for some of your patients where you might want to understand problems, allergies, or meds in the course of providing care, we can also provision you for the Connie portal. The Connie portal is a HIPAA compliant web portal. We can provision you for access to the Connie system. And then you can, with the provision of a patient roster to us, you can access data and information on your patients should that need arise while you're in the course of taking care of your patients. The account manager, remember I said the commitment to connect form was the sort of the key starting point of this. Your account manager can help with setting you up on either a direct address or access to the Connie portal if you don't have an electronic dental record and you find that there might be value for you in connecting to Connie in that way. Your account manager is really going to be the key person that will help you through that process. If you do have an EHR or an EDR, you may ask questions about whether it's compatible with Connie. We do like to pride ourselves, both the Connie team as well as our technology vendor, on having a customizable approach for organizations. We are able to connect with organizations as sophisticated as Yale, who has entire teams dedicated to interoperability and teams sort of for each type of data that they're able to send to Connie, all the way to organizations that maybe can pull together an Excel spreadsheet of their patients, but don't really have an electronic data system on there. So your account manager can help navigate through that of, I just want access to Connie. I think I have an EDR that can do this, but I'm not quite sure. We'll try to help you work through all of those processes and work with your vendor to try to figure out the best way to make that happen. This next slide is just looking at some of the dental EDR vendors that we've been working with and reaching out to. Many of these are either providing data in other states for their HIEs, and so have some familiarity with the concept of providing data to HIEs. If your dental record provider is not on here, please let us know. Please reach out, complete that commitment to connect form. Let us know so that we can, if you've got someone different, we can start work with that vendor as well and understand whether or not there's an option for them to be able to connect. So the timelines and the requirements for Connie, and this is These are Connie's dates and timelines. I do want to let you know that the Office of Health Strategy, as I said at the beginning, does have administrative oversight over Connie and also has the authority to write regulations around timelines. So far, I feel pretty comfortable that the Office of Health Strategy is really looking to encourage organizations to get onboarded. They are not looking to penalize people and bring down the hammer at this point. They believe, like Connie does, that there is value in an integrated health record, and we want to make sure that we connect as quickly and efficiently as possible those folks who want to participate. So the deadlines we've put out here are really about getting that commitment to connect form, getting your legal agreements done by the end of the year and providing a roster, and then making sure that we can get clinical data into the system by May of 2024. I want to be super clear. Our goal is to work with every provider to make this as seamless as we can. We cannot just reach into your systems and get data. That's not how any of this works. And so I encourage you to do that commitment to connect form because it starts that line of conversation and it enables us to have hey, guess what, Jen? I'm merging my practice with somebody else in a month and a half. I don't know if it makes sense for me to go to the trouble of connecting this EMR. All right, let's have that conversation. So I'd encourage the continued dialogue and the getting to know your account manager because we can work through all of these issues and your individual situations as we get past that May 3rd deadline. And again, I think I said this at the beginning, data types are going to vary. So most medical providers use a standard called HL7, and they have certain data types and feeds that we get into the system. We will work with your EDR vendors to facilitate getting the data that's more relevant to dental records. In terms of the current participants, this list is sort of not a really comprehensive list on our website. I think I have a screenshot of that next. We do have a sort of updated, up to the week list of participating organizations. As I mentioned, all of the large healthcare systems are connected. Trinity Health of New England, I believe, will be connected before the end of May on getting their data into Connie. So most of the large healthcare systems are in. Many of the large provider organizations that you're aware of, whether it's Hartford Healthcare Medical Group, whether it's the doctors affiliated with Nuvance Health, ProHealth Physicians, many of them are also already connected into Connie. And then you can see we've got a number of Medicaid ASOs, some IPAs and clinically integrated networks or ACOs that are connected in. So our goal is really to try to get to as much of the healthcare ecosystem as you see here. And the account management team is doing a great job of getting out there and doing that. As I said, on our website, we have a list of partners. It does grow every day. This list is updated, I believe, weekly. The idea really is that you can see your organization, you can see which organizations are connected, and then along the table, you can see what type of data they're providing into Connie. The idea here is you can see if your neighbors and friends are participating, but also patients can get a sense of which of their providers are participating in Connie. I call this slide sort of Connie by the numbers. Since we've been operational, this is what our data looks like. We have more than 1,200 organizations that have signed up to Connie and about 900 users at those organizations who are using the Connie system or a provision for the Connie system. We have almost 400 data feeds coming in from those organizations. And you can see sort of a breakdown of the types of messages. Maybe I should go through them because they're probably not clear if you're not in healthcare interoperability. ADT messages are admit, discharge, and transfer messages. So those are messages that come typically from inpatient systems. So if I presented at Hartford's emergency department, let's say last night, Connie gets a message as soon as I'm registered in the system to let Connie know that Jen's presented at Hartford Healthcare. What that means then is Jen's primary care physician, Jen's OBGYN, and any other providers in her care team also get a notification that Jen has been admitted into Hartford Hospital's ED. If I then get transferred up into an inpatient unit, that information comes over to Connie in real time. And then when I'm discharged, we get another message to let all of the care team know, hey, Jen's been discharged from Hartford Healthcare and maybe she's gone to a nursing home, maybe she's gone home with services. So providers on my care team can be well informed as to what's taken place. And then if you're my primary care physician, can reach out, follow up with me. Do I understand my discharge instructions? Am I aware of the medications that I need to get? Let's get you in for a follow-up appointment, that kind of thing. We also get a number of CCDs. CCDs are sort of the bread and butter of what we do. Those are continuity of care documents. Think of them like PDF summaries of episodes of care. So once you're done with a doctor's visit, most electronic medical records can produce a CCD. Once that visit is closed, the physician is done, the patient has been discharged from that practice for the day, a CCD comes automatically to Connie, and it provides a really nice summary of problems, allergies, meds, what happened in the encounter, what follow-up care is required for that patient. So it's a really nice summary of information. And then we also get lab results. So almost 9 million lab results a month coming not only from Quest and LabCorp, but also from hospitals who more and more are doing complicated lab tests in their own labs. And that data is coming into Connie to be able to be shared with providers and clinicians on care teams. And like I said, we have about 4.2 million unique patients in our master patient index. That master patient index does the yeoman's work of understanding that Jennifer Searles in Yale's system is the same as Jen Searles in Hartford system is the same as Jennifer G. Searles in ProHealth system. It gets all of that data together and it understands that this is all one person named Jen Searles and that the various members of her care team have access to data and information on there. And then one that I want to point out, because we'll go into it in a little bit, is the number of opt-outs. We have about 3,400 patients who have opted out of data sharing with Connie. And as we go sort of into the next section, I do want to maybe spend a little bit of time talking about this. The HIPAA privacy rule does allow for sharing without explicit patient consent for treatment, payment, operations, and public health purposes. Patients, however, have absolutely the option to opt out of this voluntary benefit. And so they can register their opt-out decision one time at our website. And the nice thing about that is that then an individual provider isn't trying to manage an opt-out and, I've got to keep Jen's data out of this feed. We're able to maintain that consent decision. And if we get data into our system for Jen and Jen's opted out, we immediately delete that data. We don't even ingest it. And then that way we're not sharing it. It's just not in our system at all. I can always revoke that decision if I have a conversation with my provider and we decide that, yep, I understand the value of participating in Connie. I can always revoke that decision. And from then on, my data will flow into Connie. And so I missed this sort of second bullet. Connie has an opt-out consent model, meaning you do have to affirmatively opt out of the system for us to be able to do that. And like I said, you can register on our website. We can do it one time across all systems, and you can provide us that form, whether it's, I just got one in the mail today, you can do it snail mail, you can fax it, you can complete the web form, you can email us the form, you can call an 800 number. There's a number of ways that patients can opt out of data sharing through Connie. We do have some exceptions that follow current laws, including needing affirmative consent for data like substance use disorder data from Part 2 programs. I don't know if that makes sense for folks who are not in that world, but there's very specific laws around substance use disorder data from Part 2 programs, and we follow all of those rules. All of that, though, is built on a technology platform that follows sort of the highest standards of privacy and security. Our technology partner is HITRUST certified, which is sort of the gold standard of security. I like to say that the way Connie works in terms of privacy and security is we are bound by all of the federal and state laws around privacy and security, such as HIPAA. On top of that, we have data sharing agreements. We talked about them at the beginning of this call that are really meant to make sure that we all understand our obligations with protected health information. Layered on top of that, we have access provisioning. So you don't get access to parts of Connie that you shouldn't get access to, as an example. We have things like break glass. So if you're trying to get into a patient's record that we don't have a relationship of, we've got processes to stop you for a second and say, wait, why are you doing that? We track all access in the system so that we know exactly who's been in what record, what they were doing in that record, how long they were in that record. And we do that for a number of reasons. One is to provide patients with an accounting of disclosures, and one is to feed into systems that are looking for behavior that's out of the ordinary. So we have software, AI-driven software that's really looking for those strange access or behaviors in a system so that we can then investigate what's happening. And then on top of all of that, we have a privacy, security, and confidentiality subcommittee of our board that oversees our entire privacy and security platform. So we've tried to layer a number of different mechanisms to make sure that we are protecting this really valuable, really critical data that patients are entrusting us with in Connie. And with that, Tracy, am I turning it over to you for the demo?
This is Kathleen. If I could just jump in for a second, there's been some concern that the questions that are being posted both in the chat and the Q&A would not be available to people that are watching the recording. So I think we should address that. And the second thing is the Q&A is not working very well. So we will have to jump back into those questions, and I want to make sure there's enough time for that. So just want to point that out for the record. Okay, thank you.
Sure. Yeah, I was trying to get to some of the questions in the Q&A, but we'll go through the demo and then we'll come back to some of those questions, and Carrie and Tony might be able to answer some of those as well. All right, let me start sharing my screen. All right, so this is the Connie portal. I have already logged in and I have already searched for a patient. And our test patient here, this is a fake patient, but her name is Anna Cadence. This is our test patient. So if I were a provider and I had logged in and did a search for Anna, Anna would need to be on my patient roster before I could look at her, her records. And if Anna was not a patient on my patient roster, we would get kind of a pop-up window that says, this patient is not on your panel. Would you like to continue to see this record? And then you have to give a reason why you need to see that record. And it could be things like emergency, or it could be a new patient. So you would need to select a reason why you need to see that patient's record. And as Jen mentioned, we keep track of those and audit them and just make sure that everybody's using the system appropriately. So the first thing I'm going to land on here is patient information. And this is the patient demographics that we've received, and also the next of kin. So it's nice to have the patient information here. Sometimes you may not have the correct address or phone number for a person, or they've moved. So this is the very latest that we've received from any one of our participants. The next item here is clinical data. So this really gets into the patient medical record. The first tab here is called Encounters, and we'll go through each one of these. But first we have Encounters, then we have Health Records, then we have Structured Documents. And currently aren't connected to immunizations, but hopefully that will be down the road. So we'll go through Encounters, and here you can toggle between a list of all encounters. If you only want to see hospital encounters, you can choose the hospital tab. So this lets you know that, you know, somebody was in the hospital, what their admit reason was, what the discharge disposition is, how long they were there. And then we also have outpatient encounters. So this lets you know that someone was seen at in an outpatient setting. Next, we have health records, and these are more detailed. And these are broken into, you can see all of them, or you can break it down into laboratory, radiology, and clinical notes. So we'll go over to laboratory. So these are all lab results for this patient. And you can click inside of them and see the entire report. You could also, if you see a flag here, that means that there's an abnormal result on one of the labs. So you can go in here and find out what that is. We can go to radiology. And with radiology, if these are all radiology reports, but if there's a camera icon here, that means that we have an image available. So we can click that camera icon and it will retrieve that image. And this is a diagnostic quality image. This is actually a screenshot I'm showing you right now, so it's not diagnostic quality, but it will pull up a diagnostic quality image for you. It has some tools at the top that you can use if you need to measure something. So that image share is a nice thing to have available. The next thing are clinical notes. So any transcribed notes that we receive through any of our feeds will be shared here. So these are things like op notes or care plans, progress notes. So those things will show here. That one's not very informative. It's just a test, but I think you can get the idea. And then I'm going to move over to the next section, which is structured documents. So structured documents are CCDs, or consolidated care documents. I'm going to pull up one just to show you what it looks like. So it's kind of a summary of an episode of care. So you have the patient information here at the top. You have where this came from. You have details about the encounter. As Jen mentioned, you have allergies, adverse reactions here. You have the assessment, you have medications. So it's really just kind of an all-encompassing record of that visit or encounter. And so that is it for the clinical data. Next, I'm going to go into medication management. And as Jen mentioned, in the medication management area, this is where we're pulling out all of the information, all of the medical or medicine information from those CCDs. We're pulling that out into this one section so that you can see everything all together. You don't have to go into individual documents. So they are all listed here. If you see a triangle here, that means that a dosage or provider has changed. So you can drop it down here and see that the dosage has changed on this medication. So that's kind of a very convenient to have all the medications in one section. Next is care coordination, and this is the patient's care team. So this is every healthcare provider that the patient has been to that we've received data for will be populated here. If you click on the or hover over the information icon, it lets you know what this provider does for the patient and some contact information. And if we have the provider's name, we'll also include the provider's contact information. Next is social needs data. This is a new section. So this really comes from social determinants of health that we receive in some of our ADT feeds, some of our HL7 feeds. So these are ICD-10 Z codes, and they have to do with social determinants of health, like does the patient have a caregiver at home, things like that. So those will be populated here. And then, as Jen mentioned, I'm not going to click on it because it's not connected to our demo system, but this is a link out to the prescription monitoring program. And when you click this, it will go out to Connecticut's PMP, and it will pull a NARCS report for that patient. So if that's something that you need to access before you prescribe medications, that's available right in here in the portal. I think that is it, Jen. Is there anything else you'd like me to show?
No, I think that's great.
Okay, I'm going to
Um,
go ahead and stop sharing here.
okay.
Well,
know we
thank you,
got-
Jen and Tracy. I really appreciate you kind of giving the overview. And I know the Q&As are bouncing around and we have a lot of other common questions that we're getting. So Jen, if it's okay, can I start asking you some of the questions I know we're getting in
Yeah.
bulk here at CSDA?
Sure.
First one is that, I know you talked about HIPAA and you talked about, some of the parameters to that. It would seem to me that if we have a patient that signs an opt-out form, and I know there's some questions about an opt-out form, we'll cover that in a second, but if a patient signs an opt-out form, you have the data in your system. My understanding is that the data automatically gets uploaded every evening or whatever is going to be the system, and you do not take that data out, that it goes up into the system and is then scrubbed out by other entities. I have a lot of concerns about that. I'm sure people on this call have a lot of concerns, but I think the number one thing that I'd like to focus on is, there was a question about why does it take 5 days? Who's doing the scrub? And if a patient is opted out, isn't the liability on the practitioner who receives that opt-out to make sure that data doesn't go onto the internet? That's what they're asking for.
So the data doesn't go on the internet. So I want to stop there.
Okay.
So it's not
Being
like,
uploaded.
yeah. And I'm not sure I know what you mean by scrub. So can we come back to that? Just to make sure.
Okay,
What does
so
that mean? What do you
let's
mean?
walk through a very real example, which is that I go
Sure.
into a provider, I opt out. I say I do not want my data provided to Connie.
Yeah.
So, and the provider's using Dentrix, CareStream, whatever it is. My understanding is that, like with CareStream, that Tangible has the process to take the data every night or whatever from CareStream and to upload it into the system. So how do you prevent that patient who has chosen to opt out? I don't want my information uploaded. How do you do that?
So I think we'd have to work with some EMRs or EDRs have the ability to be able to put that flag on there. So if you have like a patient portal, for example, many systems do have that ability to not allow for data to go directly to a patient portal, right? Where maybe their spouses or other folks have the ability to log in or it gets shared more broadly. So I think we'd have to investigate that. And Tracy, jump in if you've already had this conversation with some of the dental providers, because am I getting
I have.
going down there? I'll just shut up and let you talk.
So if a patient wants to opt out, and we provide all of the organizations with a communications toolkit that they can use to let the patients actually opt themselves out. You don't have to opt the patient out. So the patients would call, we've got a number, we've got an email address, we've got an online form. So the patients would do that to opt themselves out. And then even if the data is sent to Connie, if we have received the opt-out from that patient, we block it. So we block it from being received from us. We don't store that data. And then we also block it if someone does a search for that patient, they'll get a message that says this patient has opted out.
So just to clarify, the patient opts out of the system globally. They're not doing it per provider.
Yes,
And
that's correct.
At the provider level, if it is automatically being uploaded because of our system, that where does the liability end for a provider?
I don't think that we could, I'm not a lawyer, so I don't want to at all go into whose liability is where. I think that you would have to take that up with your lawyers, because I don't feel
I
like
have.
that's,
And there's liability on my providers.
okay, so this is where I go back to the question around sort of what I'm hearing you talk about is a little bit of a timing overlap, right? Like patient comes in today, finds out about it, wants to opt out, but your system is maybe already connected. Is that where the concern is?
My concern is that I represent our member providers and they have questions before they sign your commitment form, which I think is a legally binding document. So nobody's going to sign it if they can't commit to it. The second thing is that once they sign on to it, they're not sure exactly what's happening to that data. And in this particular case scenario, which is a very real life one, there's not a good answer right now. And our liability insurance carriers are telling me this is going to be a major factor. So you add that on top of the fact that, as somebody has put in the chat here, we all have been talking to the various providers, that it's going to cost a lot of money for individual providers to participate. You know, Dentrix and CareStream and others are quoting almost somewhere between $3,500 and $5,000 for the initial, and significant carrying costs on small businesses. So, you know, on top of the liability insurance issue and this, for my members who are mainly private practices, this is a very big problem.
Yeah, I understand that there are these costs. We have the same on the clinical side. Unfortunately, there's not a lot I can do about it from that perspective, other than not adding on additional costs from a Connie perspective, right? So Connie wasn't not the state, and I'm not the legislature who made this. So I'm trying the best that we can, which is why we've tried to identify additional organizations that can help, that seem to have a more cost-effective way or option of doing this than going directly to some EMRs. We have seen the full gamut with both dental providers and medical providers, where some are charging nothing for connectivity and some are charging quite a bit. So we've tried to find ways that we can help bridge the cost where we can. We are not passing along any cost, and we have no participation fees at the moment through Connie, because we're subsidized from, and that was a question someone answered, we're subsidized at the moment through a contract with the Office of Health Strategy. So there are no participation fees to organizations for participating in Connie. So we're trying to do what we can to try to alleviate that as much as possible. Again, identifying those providers like Tangible or SmartLink that can try to help with some of those costs, because we know it can be a lot.
Well, the other problem I'm having is I'm hearing in the marketplace with the different vendors, the ones that are not charging are doing it because they're trying to take away market share from other companies that we already work with. The cost, again, to a provider to participate, to avoid these fees, to go with a separate software system and integrate everything over to, I mean, that's just not doable. And so, because the way our systems work, and there's enough providers on here, I don't want to dominate the call, but you know, there's layers of our software that work on with each other. It's a domino effect. If you change one, there's a lot of other pieces of it that change your scheduling, your billing, your everything. So I just think that these things need to be addressed. And the fact that you are, and I don't mean this as you, I started the call that I want to be collegial with you, but these things haven't been figured out. So we have a deadline, and you're asking for commitment to sign to something that we can't legally do, because we can't agree to something that is an abstract. It's just not a reality.
I would say that the commitment to connect form, I don't want to say it's not legally binding, but I would say that there's no, I would say that what that form provides is an opportunity to make sure that we know who you are, and make sure that we have then an opportunity and a way to get back to you to have conversations, right? Because if we don't have that list, it's very hard for us to go back to the Office of Health Strategy and say, for example, we have, I'm going to make this up, we have 100 dental providers who all use this system. This system says it's going to be $50,000 to get connected, and nobody can do that. So what can we do about this, right? Failing that commitment to connect form, I don't have a super easy way to sort of keep track of and make sure that we're bringing those concerns to the Office of Health Strategy, who ultimately has the ability to do something about it. And it strikes me,
I understand that,
but we can maybe get the OHS to have a conversation with you guys as well.
Well, respectfully, after this call, I have counsel on this call. We are going to be drafting a letter to Deidre Gifford. So based upon, and it's not about you guys, it's that you were given something, an impossibility. And we started talking CSDA to Connie in December about this and started raising these questions. So it's not that we're late to the game, it's that there's no answers coming forward. So I also would like to just say that, you know, as we're looking at these issues, I think part of it is the fact that the way it was drafted to include all healthcare providers was not thought of. Because if you have, you know, if my medical records are in Connie already because I'm part of Yale or Trinity or whatever, how are you going to link that to my dental records?
In what way? Through the master patient index.
Okay, so if I opt out, I'm not in the index at all.
If you opt out, we maintain some demographic information so that we can match you to data that comes in and be aware that you have opted out. So we maintain like Jennifer Searles, 123 Main Street, West Hartford, Connecticut, and a date of birth. And we maintain sort of a registry that's almost the governor right before data comes in. And then we'll say, oh, this data coming in matches this person. This data is, she's an opt-out, so we don't pull it in. Is that what you were asking?
I just think that and somebody else put in the chat a very good point, which is that as a provider, one-on-one with our patients, we're the ones that are getting all these calls and all these questions. And while I appreciate the fact that Tracy said that there are some organizational level information communication going out there, we represent this profession in Connecticut. I understand that you have a mailing list right now of 258 emails. There are currently 3,289 licensed dentists in Connecticut. This whole system has not been set up well, and we have to hit the pause button. Karen has been spending probably half her day right now answering questions about Connie. We can't absorb this tidal wave, especially when we don't have answers like this.
Okay. Do you want me to go through some of the other questions that are on there?
Please.
Okay, I think we talked about the cost one. For patients that don't have access to the internet or don't know how to navigate it. Again, we do have a phone number, an 800 phone number, where someone can walk a patient through the relevant information to be able to explain the opt-out and be able to register that opt-out. And then what we typically will do in that situation is send a letter back to that person to let them know of their decision. We also give them a number if they want to be able to call back and revoke that. So hopefully that helps with that process. There was a question about if the patient has opted out, is it possible providers who have access will still have patients' data on their ends? If they have downloaded that data and information, this is no different than, let's say you faxed information. Let's say information went from my primary care doctor to my OBGYN, and then I don't want to share data anymore with my OBGYN, or I switch OBGYNs. That data or information is still in the OBGYN's chart, right? Connie doesn't go in and pull it out of other systems. We take it out of our systems. We don't share it from that point on. But similarly to how it works, in the paper world, if that data is in your chart, that data is in your chart. I'm not the technical person, so I'll try to answer this a little bit. We use the internet, or we use a web-based system as a front-end mechanism to be able to access and view, because everyone has a way to be able to access data on the internet. But it is authenticated and secure, much like when you use your bank. When you go to log into your bank and look at the data and information you have in your bank, you are using web-based protocols to be able to get there, but your data is not sort of out on the internet for everyone to have access to. So I hope that's a little bit helpful. Let's see. The question about expecting costs in the future. The Office of Health Strategy does have, like I said, the administrative oversight. They have, the legislation allows them to set participation fees. They are not planning on setting participation fees in this upcoming fiscal year, and probably not the one after that. After that, I really can't speak to, and I probably shouldn't speak for them at all on that regard. But their plan is not to set participation fees, at least in the very near term.
Jen, can you describe other states that have successfully implemented how it's working, and the reality of implementing all of this for a sustained period of time? Because obviously, if we're committing to this and we are taking on the cost to do it, explaining what it means to our patients, and then we build it and it doesn't exist in 2 years or 3 years, or it's defunct, I mean, that just seems like a colossal waste of time and energy.
Yeah, I don't see that being an issue with Connie. The state certainly has tried to set up an HIE in the past. They never got to any sort of mass and never got to getting any sort of data. And so I think this is vastly different. We are affiliated with an organization that runs the HIE for 5 states. And so has a lot of experience in working through and building an HIE. There are other states that have also incorporated dental data. They have been state-owned versus Connie, which is independent. So I don't know if that makes a difference or not. The goal and Connie's mandate within the legislature has a bit of a different bent on it, in the sense that the expectation has always been that Connie will be able to provide patients access with their complete information. And so it was always, most HIEs are built to be a communication methodology between provider organizations and not necessarily the patient. Now, with info blocking rules that require organizations that send or have electronic data to make them accessible to patients, many HIEs are now starting to work through that. However, Connie was always set up with the idea that we would ultimately be able to provide patients with full access to all of the data that's in Connie. So I don't see that there's a lot of impetus. There's been a lot of work behind the legislature to get this up and running, and a lot of commitment from the state. So I don't see this one sort of going away as the other ones did.
Jen, what is the access for insurance carriers to access Connie?
Well, so insurance carriers today, right, have the right to healthcare information on their patients, on their beneficiaries. Connie was set up with a mandate to benefit providers, the state, and insurance carriers. So our goal is not through Connie, is not to restrict payers' access any more than they have today, nor is it to expand payers' access any more today. What we do think that we provide through Connie is a way to have be more transparent and accountable. So I mentioned at the beginning that we can tell exactly who's logged in, what they've logged in, who's seen what data. That same functionality can extend across payers as well, right? So if a payer is accessing, payers today, for example, get alerts and notifications when their patients or their members are in a hospital. They could have the same access through Connie, and we can provide the same information to a patient to let them know that we sent your encounter information to Aetna on Thursday at 3. Patients can then opt out of data sharing in that regard. If they don't want to have their data shared with anyone, they can just opt out of Connie. So we think it's a more transparent system for what is already happening in the marketplace today. And we think it gives patients more control to be able to opt out that one time without having to go to each payer, each provider, and the rest.
There's a question in the chat. What would happen to a provider who does not sign up for Connie by May 3rd?
At the moment, nothing. I'll be totally candid. There's nothing in the mandate that has a penalty for participating, which is why I keep encouraging folks to go ahead and sign the commitment to connect form. That puts you in compliance with the mandate and sort of gets you on the radar. I don't know where the Office of Health Strategy is going. Like I said, I think their goal has been less about penalties or bringing down any sort of hammer on people that don't participate at this point. But that remains to be seen where they might head with that. I don't want to speak for them because I'm not sure where they're going to head. They didn't put any legislation in this year for penalties or other kind of penalties is the only word I can think of. They didn't put anything in the legislature this year, and I don't think they're planning to next year, but they ultimately decide what the mandate requires.
So in essence, there's no legislation that would allow implementation of this with penalties for the next 2 years.
At least for the next year. I don't know what they'll put in, if anything, for the year after.
Okay, and for the FQHCs that you've listed, does that include their dental work as well, or is it just medical?
It will include dental as well. And so I think there was a question about UConn Health. Similarly, UConn Health entirely has signed on to Connie. We've worked through their medical data, haven't started on dental yet. But the expectation would be that they would be in there as well.
All right, and just for the record, the question at the beginning was regarding when you say license, does that include each provider? Does it include our hygienists?
It does include, technically, the way the law is written, it does include the hygienists. What we typically will do is onboard an organization, and that organization and its users then are sort of covered under that bucket of the organization.
So if you have a per diem person coming in, if you have transitional staff, all that type of thing. It's on the actual provider to sign up?
No, so I would say in that case, where if your organization is onboarded and you have your staff there, even your per diems, sort of provision for the system, you're all set from that regard. The individual providers more comes into play when we've got sort of solo, like social workers or other folks who are maybe not working in larger organizations. But typically we've been focusing on organizations because they typically will have systems and they'll have the staff that's sort of supporting those systems.
Okay. There's a comment in the chat I just want to address, which is that regarding our cybersecurity policies, just to respond, I want to make sure that my side of the world, CSDA, that Black Talent is our provider for security issues. I've already been talking to them. They are monitoring very carefully what's happening and going to be advising anybody who's one of their clients about what they need to do to increase their cybersecurity because of this.
Okay.
There's a question from Dr. Carl about how is Connie funded. I believe he also asked the question about who is on your board of directors, like who is overseeing this from your team.
Yeah, I put a link in the Q&A on our Connie website. We have a list of all of the board members. I also put a link to the legislation. The board is appointed through legislation. They're meant to represent different constituents, and they are not compensated for their work and their time.
All right, I think we are reaching the end of our hour, so we're going to probably be shutting down the recording soon. I want to thank all of you from the Connie team for participating. CSDA side of the world, please don't inundate Karen with all your questions. She's doing the best she can to keep up on it. We are keeping the website updated. Read your e-blasts on, especially on Friday afternoons when we send them out for updated information. If you have questions, you can certainly send them to us. Kwright, KWRIGHT at CSDA.com. And then also come to the annual meeting, visit Connie's booth, and you'll be able to ask questions directly to the team. We will be at CSDA reviewing with our Board of Governors a letter to go to Deidre Gifford so we can talk directly to the Office of Health Strategies about some of the concerns that we've raised here today. But thank you very much. And Carrie, I just want to say thank you and a shout out to you because you were the toughest negotiator I had on a call with you. And at the end of it, we were laughing. So if you're at Mohegan, I still owe you a cup of coffee.
That sounds good. I'll see you there.
All right, very good. Thank you, everybody.
Thanks all.
Thank you.